Hello at Medical Sciences. In this video we are going to dive into what we call anti-cancers or antineoplastic drugs. Drugs which are being used in treatment or management of cancer. And you can ask yourself before we begin these drugs that what is cancer? And cancer is uncontrollable or uncontrolled proliferation of cells. We know that during cell cycle, cells are controlled by certain genes called cyclins. So in case those genes that do a role in regulating of the cell division and cell proliferation fails, then we see cancer cells coming up. And as we begin to see the drugs which we use to treat these cancers, please, we request you to subscribe. That is the only gift you can give unto us, that we can continue to grow and make more videos. So subscribe if you haven't done it. Like the video if you enjoy it, and then share to many others that they can continue to learn. So before we begin anti-cancer drugs, let us look briefly on a snapshot of the cell cycle. And this cell cycle begins with the gap 1 phase, which we call G1 phase, whereby in G1 phase, the cell is preparing to enter synthetic phase, or what we call DNA replication. So it is making sure it is making enough enzymes responsible for DNA replication, making enough proteins required, like the nitrogen bases. Then it enters into what we call the S phase. And S phase is known as synthetic phase, where at this phase we see majorly DNA replication. Here we see DNA replication under synthetic, whereby the DNA is undergoing dividing to make more copies. That is during S phase. And as cells are leaving S phase, there is a checkpoint known as S/G2 checkpoint. At this checkpoint, the genes known as the cyclins check if there is any damage or any mispairing of genes and any abnormal genes that have been formed, so that they cannot proceed to gap 2 phase, which we call G2 phase. So before G2 phase, we see a checkpoint, which will only allow DNA which have been well paired, DNA which are well functioning, to proceed to gap 2 phase. And under gap 2 phase, only we see preparation to enter M phase. And within gap 2 phase, we are making sure that all the materials required for mitosis is being manufactured in gap 2 phase. That is the spindle fibers, the microtubules, the asters, the chromosomes are being prepared so that the cell enters what we call mitosis or mitotic phase, which we abbreviate as M phase. And within M phase, before the cell moves from gap 2 to M, there is also another checkpoint. And this checkpoint, the cells are checked for any presence of abnormality or damage before it proceeds to cell division, what we call mitosis phase. And when it reaches in mitosis phase, it undergoes processes known as IPMAT, that is interphase, prophase, metaphase, anaphase, and telophase. So that, and these processes are the one which we know as cell division by mitosis, whereby one daughter cell gives to one parent cell, gives 2 daughter cells, and they continue dividing by 2. That is under mitosis. And that is interphase, prophase, metaphase, anaphase, and telophase. But in our discussion, we are going to see that we see some drugs which target metaphase. Shall see some drugs that target metaphase of mitosis phase. So we shall discuss about it, which drugs can either inhibit M phase via metaphase drugs which can inhibit synthetic phase, drugs which can inhibit GAP2 phase, so that we can be able to treat our cancer. And as we start, we're going to see that there is what we call drug combinations, where currently we are combining drugs with different mechanism of action, drugs with different toxicities, and drugs which are very active, so that we can achieve our therapeutic goal of stopping cell proliferation, hence treating cancer. And these drugs are divided into two, where we shall see drugs which are cell cycle specific, and those ones which are cell cycle non-specific. And here example is alkylating agents, whereby alkylating agents, we shall see that they are cell cycle non-specific, and these ones target both actively dividing and resting cells. So the cell cycle non-specific drugs are used to treat both actively dividing cells and resting cells, whereas cell cycle specific drugs, for them we are going to see antimetabolites being cell cycle specific. Antimetabolites, we're going to see microtubule inhibitors, then we are going to see topoisomerase inhibitor, and some antibiotics. That these ones, for them, they work on actively dividing cells only, actively proliferating or dividing cells only. So they are good at actively dividing, whereas the cell cycle non-specific, for them, they are good on both actively dividing and resting cells. So we can now start individual drugs. So we're going to begin with these which are cell cycle specific, and we shall end with those which are cell cycle non-specific drugs. And not forget that apart from these which based on the cell cycle, we also have hormones which can be used to treat cancer. Hormones like estrogen, hormones like glucocorticoids, or what you can call corticosteroids, androgens. Then we shall also see radiations being used. But as our discussion is on drugs, we are going to look at those which are on cell cycle. So let us begin with antimetabolites as our discussion number one. So our one class is antimetabolites, and these antimetabolites, they are specific, they target synthetic phase, that is during DNA replication. So antimetabolites, for them, they target the S phase of the cell cycle. And these antimetabolites, examples include, they are divided into three, whereby we have folate antagonist, we have purine analogs, then we shall also look at pyrimidine analogs. Pyrimidine analogs. So these are all antimetabolites which are being utilized to inhibit synthetic phase of the cell cycle, so that we don't form many copies of the DNA and RNA, which can cause uncontrollable cell division. So with the folate metabolite, here the peculiar example is methotrexate. Methotrexate is the example, which we can abbreviate as MTX. So this drug MTX, which we are calling methotrexate, is being currently used widely for treatment of actively dividing cells in cancer. And it is a prodrug whereby when taken, this MTX is converted into an active metabolite known as 7-hydroxymethotrexate, or you can call it a polyglutamate. And when we form this polyglutamate, its mechanism of action is that this 7-hydroxymethotrexate inhibits dihydrofolate reductase enzyme. This dihydrofolate reductase enzyme, during folic acid metabolism, when we have PABA, it is converted to dihydrofolate by dihydroopterate synthase. Then the dihydrofolate is converted to tetrahydrofolate, which later gives us folic acid. So when we inhibit dihydrofolate reductase enzyme, meaning we are not able to form folic acid. And without folate, or what you can call folic acid, this is the precursor for the synthesis of DNA and RNA. So this one leads to the inhibition of formation of DNA. And that's how this methotrexate works, by inhibiting dihydrofolate reductase involved in folic acid synthesis, and without folic acid, we cannot form DNA. And that's how we are able to achieve our therapeutic goal. And this drug is being used or indicated in maintaining remission. What does remission mean? Remission means that when you're treating someone of cancer, the signs and symptoms disappear. And we are able to maintain remission by giving methotrexate in children with acute lymphoblastic leukemia. Acute lymphoblastic leukemia, to maintain remission or maintaining the disappearance or the stoppage of signs and symptoms. This drug is still being widely used in ectopic pregnancy, treatment of ectopic pregnancy, still being used in treatment of cholangiocarcinomas. So maintaining remission in children with acute lymphoblastic leukemia, treatment of cholangiocarcinomas and ectopic pregnancy, together with also treatment of rheumatoid arthritis. You can also use it for treatment of rheumatoid arthritis. And the major side effect of this methotrexate is alopecia. So this has side effects like alopecia, causes alopecia, that is hair loss. It causes bone marrow suppression. Bone marrow suppression, meaning before someone is put on methotrexate, they should do a CBC to rule out aplastic anemia. Also, this one can lead to nephrotoxicity. So alopecia, bone marrow suppression, peripheral toxicity, or neuropathy toxicity, and also mucositis. So if these side effects of methotrexate appear in patients who are on this treatment, we can give an antidote. And the antidote for methotrexate is known as, we can give an antidote known as leucovorin. Leucovorin is an antidote. You can call it leucovorin or folinic acid. This leucovorin is able to reduce the side effects of hair loss, that is alopecia, bone marrow suppression, and mucositis, that is inflammation of the mucosa membranes. So that one you can use an antidote as leucovorin or folinic acid to reverse the side effects of methotrexate. And this methotrexate is contraindicated in pregnancy, so don't give methotrexate in pregnant mothers because it is teratogenic. It has teratogenic effects. So other drugs and under antimetabolite we are going to see are the purine analogs, and under purine analogs we are going to see drugs like under purine analogs we are going to see drugs like 6-mercaptopurine, 6-mercaptopurine. We're going to see drugs like 6-thioguanine, 6-thioguanine. We're going to see drugs like fludarabine, fludarabine. These are the major 3 drugs seen under purine analogs. Purines include guanine and adenine, where 6-mercaptopurine inhibits synthesis of adenine, whereas 6-thioguanine inhibits synthesis of guanine, which are the 2 purines we have. And these purine analogs, they are prodrugs. For example, the 6-mercaptopurine and 6-thioguanine are prodrugs which are converted into their active metabolite, forming triphosphates. And after forming the triphosphates, when incorporated during DNA elongation step, that is during a DNA replication, when these guys are incorporated within the strand during strand elongation, they terminate the DNA, leading to DNA termination. So these ones cause DNA termination by competitively inhibiting DNA polymerase when these 2 drugs, 6-mercaptopurine and thioguanine, are incorporated during DNA chain elongation, leading to premature DNA, which is finally degraded by apoptosis since it is immature. So this one is cause termination, hence failure to form purines like adenine and guanine. So these ones cannot be synthesized. Whereas fludarabine, for it is also responsible for inhibiting DNA polymerase. It inhibits DNA polymerase, and it is a competitive inhibition when we form a triphosphate from fludarabine by the presence of cellular kinases. That when formed, this fludarabine also inhibits DNA replication, which by inhibiting the function or the manufacture of purines, whereby that when fludarabine is incorporated, it competitively inhibits the action of DNA from incorporating the real nitrogen bases, leading to DNA chain termination, and we are not able to form the right purines. So this is what we can talk about under this. Their mechanism of action by inhibiting synthesis of purines, that is adenine and guanine, at the same time causing chain termination of the DNA. And we are not able to manufacture many of the DNA during synthetic phase. And these drugs are being used in treatment of lymphomas. This one are being used in treatment of like Hodgkin's lymphoma, the acute lymphocytic leukemias, and acute myelocytic leukemias. These are methotrexate and 6-thioguanine being utilized in the treatment of leukemias, that is hairy cell leukemias, non-Hodgkin's lymphomas, and acute leukemias. And in case their side effects are the same as methotrexate, that is alopecia, hair loss, bone marrow suppression, mucositis. And when these ones occur, with these drugs, that is purine analogs, you can give an antidote known as allopurinol. Allopurinol mouthwash is an antidote we can utilize to reverse the side effects of 6-mercaptopurine and 6-thioguanine. You can use allopurinol mouthwash, which is able to counteract these effects of these drugs. Indicated in the treatment of acute leukemias, non-Hodgkin's lymphomas, and lymphoblastic leukemias, chronic ones, and even hairy cell leukemias. So this is what we can talk about under purine analogs. Then we have pyrimidine analogs. With pyrimidine analogs, these ones include 5-fluorouracil is one of them. We have 5-fluorouracil. We shall have drugs like citalabine, and gemostabine. So these are major 3 drugs which are under pyrimidine analogs, which inhibit synthesis of pyrimidines like uracil, pyrimidines like cytosine, and thiamine. And how do they do? For example, a drug like 5-fluorocytosine is converted to F-dump, that is fluorouracil deoxyuridine monophosphate. And this deoxyuridine monophosphate acts by inhibiting thymidylate synthase. Inhibits thymidylate synthase, which is responsible for the synthesis of the thymine, which is a nitrogen base. So when you give 5-fluorouracil as a drug, and this drug crosses the CNS, it has ability to cross the blood-brain barrier, so it can cause neurotoxicity. So when it forms F-dump, it inhibits the synthesis of thymidylate synthase, responsible for the synthesis of thiamine, which is responsible for the formation of DNA. So without thiamine, you cannot form DNA, and we are able to arrest or synthetic phase. But as if this is not enough, apart from inhibiting this enzyme, we can continue, and in presence of a kinase, we form FDUTP, that is fluorodeoxyuridine triphosphate. And this one, when incorporated, it causes DNA chain termination. So it can inhibit DNA replication. How? By inhibiting synthesis of thymine, or by causing premature chain termination during elongation stage. And it has ability to cross the CNS. So the side effects, apart from bone marrow suppression and mucositis, it can cause neurotoxicity, because it can cross the blood-brain barrier. And this 5-fluorocytosine is used in combination with microtubule inhibitors like vincristine, vinblastine, and vinorelin. And they are being used in the treatment of leukemias. So that is 5-fluorouracil, its work. So being used in treatment of different leukemias and ovarian cancer, you can use 5-fluorouracil. Whereas citalabine and gemostabine, for them they have the same mode of action. In the presence of kinases, cellular kinases, they incorporate ATP, leading to formation of diphosphate and triphosphate. and triphosphate, whereby we shall have arabinosine, diphosphate, and triphosphate, and also this form. And when these incorporated in the DNA during DNA replication by DNA polymerase, they cause DNA chain termination, leading to premature DNA formation. Because these ones, they are analogs that when DNA replication, DNA polymerase is incorporating nitrogen bases complementary to the parent strand or template strand, when they combine or when they incorporate these triphosphates from these two drugs, they immediately causes chain termination because they lack the OH group at carbon number 3 when incorporated, leading to DNA chain termination. And when that one happens, we cannot form a mature DNA. But apart from that, they also directly inhibits synthesis of uracil, thymine, and cytosine. That is what we can look at their mechanism of action. Being also utilized in the treatment of leukemias, especially acute leukemias. The side effects still remain the same: alopecia, bone marrow suppression, mucositis, and nephrotoxicity. These ones can lead to that. So the side effects still remain as methotrexate, and also, for example, the toxicity of 5-fluorouracil, you can also use allopurinol as an antidote. So the antidote for toxicity of 5-fluorouracil, you can use allopurinol mouthwash, cause their major side effect, they cause mucositis. So we can use allopurinol mouthwash to counteract their effect. So this is what we can discuss under antimetabolites, where we have looked at folate antagonists, that is methotrexate, purine analogs, and pyrimidine analogs, that is 5-fluorouracil, cytarabine, and gemcitabine, responsible for inhibiting synthesis of pyrimidines and leading to arrest of synthetic phase during cell cycle. So the second class we are going to discuss with you. Hope you guys, you're enjoying my video. Keep liking, keep sharing. So another type we are going to see is microtubule inhibitors. Microtubule inhibitors. And these microtubule inhibitors, they target metaphase, especially metaphase of mitotic phase, of mitotic or cell division. And they are categorized into two, whereby we have the vinca alkaloids. We have vinca alkaloids. These are natural drugs derived from plants. This one is derived from vinca rosea, which is derived from a plant known as vinca rosea. And these vinca alkaloids include drugs like vincristine, vinblastine, and vinrerin. So these drugs, they begin with a prefix vin, vincristine, vinblastine, and vinrerin. These are vinca alkaloids extracted from a plant known as vinca rosea. And their mechanism of action, these ones, they act by causing or by inhibit microtubule assembly. And how do they? So these ones, they are known as microtubule destabilizers. These are known as microtubule destabilizers. Why? When they bind on the tubulin, We are here during metaphase. And within metaphase, we have these microtubules which form. So what happens, the vincristine and the vinblastine, they come and bind on the tubules of the mitotic spindle fibers. And when they bind, they don't allow them to undergo polymerization. Remember, at the beginning of the cell, it is thread-like in nature. So we need to condense to form dimers with these spindle fibers so that they can polymerize to align at the equator of spindle, holding chromosomes at their kinetochore. So if I inhibit dimerization or polymerization of these microtubules to align at the equator of spindle during metaphase, we are not able to continue with mitosis. They will not be able to pull the sister chromatids to the opposite poles, non-sister chromatids. And that's why we are seeing it is a microtubule destabilizer by inhibiting polymerization of the tubules. And when it inhibits polymerization, they are not able to form functional microtubules responsible for pulling the sister chromatins to the opposite poles. That is what vincristine, vinblastine, and vinorelin are doing. And these drugs, as we saw, they are used in combination with drugs like the antimetabolites, and they are being used in treatment of acute leukemias, acute lymphoblastic leukemia. We can utilize vinca alkaloids in treatment of people with those conditions, and other types of lymphomas. So we can see in acute lymphoblastic leukemia, treatment of lymphomas like Burkitt lymphoma, and also treatment of breast cancer. Treatment of breast cancer. That's why we can apply these drugs but use it in combination. Their major side effect of these drugs, they can also cause alopecia, bone marrow suppression. They can also lead to neurotoxicity. Those are some of the side effects of these drugs. Bone marrow suppression. They can cause bone marrow suppression, alopecia, neurotoxicity, and so on. So these are the vinca alkaloid, which is one category of the microtubule inhibitors. The second category is the texanes. We have also texanes, and texanes, these are very cytotoxic drugs, and examples of texanes. Maybe before we look at examples, let us look at their mechanism of action. These ones are known as microtubule stabilizers. These ones are destabilizers, but these are stabilizers. So for them, they promote polymerization. They promote polymerization by binding to the beta tubules of the microtubules, and when they bind, for them they promote polymerization of the microtubules. And when they polymerize by promoting formation of the dimers, they stabilize these microtubules that they will fail to separate during metaphase. And when we fail to separate by pulling to the opposite poles, because they have been stabilized, they are stabilized after forming polymers, so they are not able to pull apart to the opposite poles when we are entering anaphase. So hence preventing mitosis or cell division. So we are saying these drugs, they bind to the beta tubulins of the microtubules, causing polymerization of these cells, hence becoming stable, and they cannot pull apart during cell division. And these drugs are very cytotoxic, and examples include they end with a suffix taxel. These ones end with a suffix taxel. And examples include paclitaxel, we have docetaxel. These are some of the examples which we can use in the treatment. And these drugs are very cytotoxic. They are only being utilized in the treatment of multi-drug resistant tumors. These ones are being used in treatment of multi-drug resistant tumors. If you have tried to treat with other drugs and those drugs are not, the tumors are not responding, that's when you can resort to paclitaxel and docetaxel to treat those multi-drug resistant tumors of the ovary, cervix, maybe it can be lung tumors, stomach tumors, and so forth, and colon tumors. So these are the taxanes. And another example we can give is carbaxtatine is also another drug you can look at under this drug. So all of them end with the suffix "tacel," if you can always remember. Very poisonous, only used in the treatment of multi-drug resistant tumors. Side effects the same as the zinc alkaloids, alopecia, that is hair loss, bone marrow suppression, neurotoxicity, and so forth. So this is what we can look under the second drug known as the microtubules. And all these two classes are cell-specific, targeting highly proliferative cells. So let us go to category number 3, which is under still cell cycle specific drugs. And these cell cycle specific drugs, another category we can mention is the topoisomerase inhibitors, whereby we have topoisomerase type 1, and we are going to look at topoisomerase type 2 inhibitors. So these are topoisomerase inhibitors, type 1 and type 2 topoisomerase inhibitors. And these topoisomerase inhibitors, topoisomerase, what is its function? That is the first thing we need to know. That during DNA replication, if I form a replication fork, as helicase is cutting, it causes what we call supercoils. So I have this as DNA as replicated, then this one forms what we call supercoils. So these are the supercoils formed during DNA replication by helicase enzyme. So as it is cutting, it creates the supercoils, and these supercoils are loosened or they are removed by topoisomerase, especially topoisomerase 2. That is one we call DNA gyrase, which is responsible for removal of the DNA supercoils so that helicase can continue to cut DNA strands. So if you give a topoisomerase, especially type 2 inhibitor, they act by inhibiting the removal of the DNA supercoils, hence helicase cannot cut to form 2 strands. That is their action. And example of topoisomerase 1 inhibitors, examples we are going to see is the topotecan and irinotecan. Those are topoisomerase inhibitors. Type 1. We have drug like topotecan and irinotecan. These are the 2 drugs. For them, they inhibit topoisomerase type 1, and when it is inhibited, DNA replication cannot proceed. And this one, meaning their S phase specific drugs. They target the synthetic phase and also the checkpoint to enter GAP2 phase. Those are these drugs, and used also in treatment of leukemias and lymphomas. Whereas topoisomerase type 2, these ones, as we have seen, they inhibit removal of the supercoils. And examples here we have etoposide. Etoposide is one of the drug which is cell cycle specific, which is acting by inhibiting DNA gyrase, which we call topoisomerase type 2. And these drugs are also very cytotoxic, so they are used also in treatment of colorectal cancer, cervical cancer, and ovarian cancer, which have been resistant to other drugs. We can use topoisomerase 2 inhibitors to treat those. That is etoposide being used. But there are also some antibiotics that target DNA gyrase, that is topoisomerase 2. That is drugs like doxorubicin, epirubicin, and dinorubicin. They also act by inhibiting DNA topoisomerase type 2. So this one marks the end of cell cycle specific drugs, whereby these two we have seen they are also targeting S phase and also entry of the GAP2 phase. So now let us look at the cell cycle non-specific, and those are known as alkylating agents. And it's going to be, these are cell cycle non-specific drugs. And we are going to look at class 1 being alkylating. So here we have finished with 4 classes, that is 2, 3, and 4, under cell cycle specific. So now let us look at alkylating agents. And alkylating agents, as their name suggests, these drugs, they cause alkylation. That if I have DNA, this is my DNA, and this DNA has nitrogen bases, and these drugs majorly target at N7 position of the guanine. They target at nth position of the guanine, that if here there is the nth position of the guanine, the drug comes and binds there. If here there is another nth position, it comes and binds, causing cross-linkage. So when they bind on the nth position of the guanine group in the DNA, they induce what we call cross-linkage. Cross-linkage. And when the DNA cross-link, we are not able to perform DNA replication during elongation. So this DNA is going to be damaged or removed by apoptosis. After cross-linking, it is removed by apoptosis. That is how these alkylating agents do. They do by causing cross-linking of different DNA strands by binding at the nth position of the guanine group, of the guanine nucleotide base, leading to cross-linking. And when they cross-link, we can no longer synthesize our DNA strands. So if long strands are formed, the cell and this DNA undergo apoptosis, leading to their removal, and we are able to stop their replication. And examples of alkylating agents, we have one is, we have nitrogen mustards. Nitrogen mustards. We have nitrosoureas. Nitrosoureas. We have other drugs like alkyl sulfonate. We have alkyl sulfonate. We have other category of alkylating agents like triazenes. We have also another category known as triazenes, and lastly, platinum analogs. So these are different categories of alkylating agents. So with nitrogen mustards, these drugs, examples of nitrogen mustards include cyclophosphamide, ifosfamide, we have chlorambucil, and we have also bendamustine, and also melphalan. These are some of the drugs seen under nitrogen mustards. And these cyclophosphamide and ifosfamide, they form a toxic metabolite known as acrolein. And this acrolein causes what we call cystic hemorrhagic cystitis, can lead to hemorrhagic cystitis. And how do we reverse this toxicity with cyclophosphamide and ifosfamide? Is by giving an antidote known as messina. So when you give an antidote known as messina with hydration, with increasing hydration, you are able to counteract its side effect of causing hemorrhagic cystitis, seen commonly with cyclophosphamide and ifosfamide. And these nitrogen mustards, they majorly target cells dealing with lymphocytes. So any kind of lymphoma, any kind of lymphoblastic leukemia can be treated using nitrogen mustards. So it is being utilized, these drugs are being utilized in treatment of lymphomas, different types of lymphomas. It can be Hodgkin's and non-Hodgkin lymphomas, hair cell lymphomas, Burkitt lymphomas, and acute lymphoblastic leukemias. So lymphoblastic leukemias and all types of lymphoma, that is Hodgkin's lymphoma, Burkitt lymphomas, hair cell lymphomas, we use nitrogen mustards. That is ifosfamide, cyclophosphamide, chlorambucil, bendamustine, and melphalan. Those are the drugs we can use as in the treatment. But apart from that, this melphalan is good for treatment of multiple myelomas. So melphalan itself is being utilized in treatment of multiple myeloma. That is the cancer that affects the gamma cells responsible for formation of immunoglobulins. So someone with multiple myelomas, that is the cancer affecting the gamma proteins, you can give melphalan in treatment of multiple myelomas. So other side effects apart from hemorrhagic cystitis, we have nephrotoxicity, then GIT, distress like vomiting and diarrhea, not forgetting also causing bone marrow suppression. And these drugs are known to cause delayed neutropenia. They cause delayed neutropenia. Those are nitrogen mustards, but the side effect of hemorrhagic cystitis is counteracted by giving messina and increasing hydration. Okay, so let us continue with nitrosoureas. And these nitrosoureas, for them, they are lipid soluble. These guys are lipid soluble, highly lipid soluble, and they are able to cross the CNS. These ones cross the CNS, that is nitrosoureas. And these drugs include drugs like camastin. We have camastin, we have romostin, we have semustin or semastin, and streptozocin. These are the 4 drugs which can be seen under nitrosoureas, which are highly lipid soluble and crosses the CNS, meaning they can cause neurotoxicity. So camastin, romostin, semustin, and streptozocin, these drugs are, because they cross the CNS, they can be used in treatment of gliomas and brain tumor. So they are drugs of choice for treating gliomas and brain tumor because they have ability to cross the CNS. Then streptozocin, for it targets the beta cells and is being used in treatment of insulinoma. And its major side effect, it can lead to hyperglycemia. So the side effect of streptozocin can lead to hyperglycemia, but it is being utilized in the treatment of insulinomas. Someone having hypoglycemia due to insulinoma that is affecting the beta cells of the pancreas, you can choose streptozocin as a nitrosourea to treat that. Then romostin, camastin, and semustin for treatment of gliomas and tumors. Side effect, one of them is neurotoxicity. Then another one is hyperglycemia and peripheral neuropathy. You can see those are the side effects of nitrosoureas. But don't forget streptozocin treatment of insulinomas. Another class that is alkyl sulfonates, and under alkyl sulfonates, the peculiar drug is busulfan. Busulfan is a drug which is under alkyl sulfonates, and it is also being utilized in the treatment of different cancers. So busulfan, for it, is an alkyl sulfonate under nitrogen mustards. And for it, its mechanism of action is that it also does cross-linkage of the DNA, leading to apoptosis or removal of the DNA by apoptosis. And this busulfan is being used in the treatment of chronic myeloid leukemia. And its major effect is hyperuricemia. It can lead to hyperuricemia, that is gout, which can result into gout. So when someone is on busulfan, they must be checking levels of uric acid when they are treating people with chronic myeloid leukemia. That is busulfan. And its role, it causes cross-linkage by forming carbonium ions. It forms the carbonium ions which destroys the DNA. Treatment of CML, and its major effect is hyperuricemia, which can lead to gout. So you must be testing for levels of uric acid when you are giving busulfan, which is an alkyl sulfonate. So we have another class, which is triazenes. And triazenes, a peculiar example of triazenes, we have dacarbazine. Dacarbazine as a peculiar example of a triazine. And another example we can see under triazines is temozolomide. Temozolomide is also being a drug of choice currently for treatment of gliomas and brain tumor. So if you don't use nitrosoureas for treatment of brain tumor and gliomas, you can also use temozolomide as a drug of choice for treatment of those conditions. So these triazenes, for them, they act as methylating agents. They act as methylating agents. So they add the methyl group in the DNA formation. And when they add a methyl group, they cause cross-linkage at the same time, leading to removal of the DNA by apoptosis. That is triazenes, which we have seen a peculiar example of temozolomide being a peculiar example. So for dicarbazide, dicarbazine can be used in treatment of conditions like Hodgkin's lymphoma, but temozolomide treatment of gliomas and brain tumor. So the last category in our discussion is under the alkylating agent is platinum analogs, and there is a reason why we have put it as number last, as platinum analog, and this is not a true alkylating agent. These platinum compounds, they are not true alkylating agents. For them, their mechanism of action is they bind to the iron and copper. They use iron and copper, and when it forms these compounds, for them, they lead to formation of the analogs which prevent DNA replication. So platinum analogs are not true alkylating agents, but they also act as alkylating agents by causing alkylation of DNA. And examples of these drugs, they end with suffix platin. They end with suffix platin. And we have examples like cisplatin. Can have examples like cisplatin. We have cisplatin as an example. Cisplatin is the example, and these drugs of platinum compounds, they target solid tumors. Tumors which can affect the lungs, the liver, the stomach, the colon, the ovary, the cervix. All solid tumors are treated using platinum analogs. And other examples of platinum analogs, we have carboplatin and oxaliplatin. We have carboplatin, then oxaliplatin. These are the three examples we can see. All of them ending with the suffix platin because they are from platinum compounds. So they are being used in treatment of solid tumors. Solid tumors can be breast tumor, it can be lung, it can be liver, it can be colon, it can be cervix, it can affect the ovarian. All solid tumors, we can utilize these platinum compounds in their treatment. And their major side effects of these platinum analogs is nephrotoxicity. These guys cause much of nephrotoxicity. They cause nephrotoxicity as their major side effect. So the adverse reaction with this is nephrotoxicity. Apart from with others, but the major peculiar one being nephrotoxicity, and we can prevent this by giving mannitol. If we give mannitol, we are able to increase their excretion so that they do not cause kidney failure. And that is the antidote we can use when we are utilizing platinum analogs, which are used in the treatment of solid tumors. So lastly is the antibiotics in our session. Which antibiotics are being utilized in also treatment of this cancer? And among antibiotics we are going to list is the bleomycin, mitomycin C. Then we shall have actinomycin D, actinomycin D. Then we are going to have we have what we call anthracyclines, which include doxorubicin. These ones end with rubicin. Doxorubicin, dinorubicin, epirubicin. So these ones end with the suffix rubicin, epirubicin. So this doxorubicin, dinorubicin, and epirubicin, these are anthracyclines, and for them we saw their mechanism of action inhibiting DNA gyrase, which we called topoisomerase type 2. These are the doxorubicin, dinorubicin, and epirubicin. They are always given in combination with other drugs like platinum analogs, like the zinc alkaloids, in treatment of cancer. And their mechanism of action inhibiting DNA gyrase, responsible for loosening their supercoils. Whereas briomycin and mitomycin, these ones form superoxides. These ones form superoxides. And these superoxides formed, they damage the DNA. They lead to DNA damage. So these drugs are very cytotoxic, and they're also being given in multi-drug resistant when you are treating, that is cervical cancer, colorectal cancer, and ovarian cancer. If they are failing to respond, you can also combine these briomycin and mitomycin C in the combination so that they can be able to respond to treatment. That is the briomycin antibiotic and the mitomycin. Then actinomycin D, acts by inhibiting RNA replication, RNA transcription. For it, it targets RNA transcription, that is actinomycin D, by inhibiting RNA polymerase, which participate in transcribing DNA into messenger RNA. So this one, for it, it prevents formation of messenger RNA. That is actinomycin D. Then we have seen doxorubicin, dinorubicin, and epirubicin being used in combination with either zinc alkaloids or even antimetabolites in the treatment of lymphomas and leukemias. Then briomycin and mitomycin being very cytotoxic, only used in multi-drug resistant tumors of the cervix, ovary, and colon. You can utilize together with the stomach cancer. You can easily use briomycin, but not given alone, but given in a combination. Hope you guys, you have learned something. If you have learned something, please go on the like button, like the video, share to many others, and if you haven't subscribed, please subscribe. May the good Lord bless you.